All right, so thanks everyone for joining. This is the first of hopefully many multidisciplinary research rounds, and I'm going to give a little bit of a brief intro into kind of why we started the rounds and kind of how we can be involved with it. And then Murat's going to actually talk about one of the studies that's ongoing in the unit. If you guys have to step out at any time, please just step out and enjoy the pizza here. For those online, thanks for joining as well. All right. When I thought about research as a medical student, as a resident, I often thought of it as a very like top-down process. You have the researcher, and the researcher comes up with a question, and then everyone does the study and the research. It's very like researcher-centric and it's very top-down. But we know that actually research is much better when it's part of this life cycle where there's ideas being generated, but those ideas are being generated by the people at the bedside. They're being generated by all of us. And then the knowledge that we're actually generating from the research is being shared to the bedside and vice versa. And that allows us to actually create really successful research studies. It allows us to actually achieve patient impact. That's this diagram here that I think I'm going to remove for the next presentation because this is what I'm doing my master's in. And even then, I don't think I can explain all of it. But the purpose of these rounds really is so that we can improve the quality of research here in London. And really that goes down to having everyone involved in the process, having ideas being brought by the nurses, respiratory therapists, allied health, and hopefully we can improve kind of the research we're doing here. Our hope is that these rounds will be every month on the first or second Monday of the month between 2 and 3 p.m., kind of with the 2 sessions. Please give feedback on whether the timing works, whether or not we should be doing it early, later. We tried to solicit as much feedback as we could when we were designing this, but we want to iterate on this process and really improve it in the months to come, with the ultimate vision that right now we're talking about current research. But imagine down the road where this is a forum for people to actually bring new research ideas. If there's a project you've said, hey, it would be really cool if we could look at this, this could be the forum. And then we could bring kind of those ideas here. And then we have the methodologists that have the kind of stats and all the kind of research methods. And then we can really collaborate on it and create a bit more of a kind of multidisciplinary research team. And really how we can help at this point is let us know what you want to learn about at these sessions. How can we make this better? How can we make it more useful? Shoot myself or Murad an email. This is really just a starting point. So thank you guys for being here. And if you say we need more pizza, we need more drinks, coffee, whatever it is, whatever we can do to make this more engaging and really a valuable session. So thank you guys for coming here. I know that things are busy in the unit.
Okay, thanks, Ross. So we'll talk today about NeuPaRT study. Some of you may have heard about, some may have participated in this, but we thought we'll start with this one. And I'm presenting on behalf of myself and Tennille Gofton and hundreds of other people, collaborators, co-investigators, both in London and across Canada. So I'll start off by stating the research question. And it goes something like this. In patients who have controlled withdrawal of life-sustaining measures in the ICU, when does brain activity and blood flow stop relative to circulatory arrest? And you'll be like, okay, why? All right, like who cares? All right, so it turns out that science cares, right? And they're like, why? Why would science be ever interested in research that we do at London Health Sciences Center, right? So a lot of this has to do, understanding the neurophysiology of the dying process has many implications. Key among them would be donation, organ donation after circulatory termination of death, and we'll talk a little bit more about that. But just generally, understanding what happens to the brain as patients progress from full life support to dying is of interest to the general public. And that's why I think it's some of our work has drawn interest from science. There is a novel donor intervention technique called normothermic regional perfusion, which should solve our shortage of organs. But it comes with a lot of controversy, right? And so this is why our work was featured in this issue of the journal. You can do a QR code and take a look at if you're interested. So the first thing I want to talk is why NeuPaRT. But before we talk about NeuPaRT, it's worth talking about DPART. Some of you may have remembered this study. Ash is nodding. This was many years ago. So, well, not so many years. Many years ago, we started thinking about it many years ago, but this at least a decade ago. But this was a study that was done in multiple ICUs in 3 different countries, and it enrolled patients who had a planned withdrawal of life-saving measures in the ICU, and then they recorded their vital signs, so arterial blood pressure, heart rates, and oxygen saturation. And we recorded it for about 10 minutes before withdrawal, for 30 minutes, for the duration of the withdrawal and the dying process, and for 30 minutes after circulatory arrest. And the question that NeuPaRT study asked was, when after circulation stops, what proportion of patients have spontaneous resumption of circulation, right? So it stopped. And then in what number of patients does it resume by itself, called autoresuscitation? And what is the time period from when circulation stopped to when it resumes again, right? And why does it matter? Because it matters because in donation after circulatory determination of death, we currently use the 5-minute criteria. What does it mean? So that we withdraw life-sustaining measures, the patient has gradual reduction of blood pressure and oxygen levels, and eventually the heart stops, circulation stops, and then we observe the patient for 5 minutes. And if their circulation does not restart, we declare them dead and they go to the operating room for organ recovery. However, if their circulation restarts, we wait for it to stop again, and then we'll wait for 5 minutes. We need that 5-minute period of time to determine that someone has died, that this is a permanent event. How did we pick 5 minutes? This was before NeuPaRT. Some jurisdictions had 90 seconds. Some had 20 minutes. In Italy, they used 20-minute wait period. So it was variable, right? So this was going to be the first study. NeuPaRT was the first study to actually look at this systematically at multiple centers across 3 different countries, right? So that's why it was published in the top journal, the New England Journal. So what we found was that we enrolled 631 patients, 480 of them had good enough waveforms for analysis, and the autoresuscitation happened in about 14% of those patients. So in 40% of patients, circulation stopped, and after some period of time, it resumed again. Just pretty high, if you ask me, right? Like, you think that something's permanent, and it's really not. Now, it resumes, but sometimes it resumes for a very short period of time. And the pulse pressure or the blood pressure generator is very low. It's like 30 on 10 and so on, and goes on and it stops again. But the longest time from cessation to resumption was 4 minutes and 20 seconds. So 5 minutes was okay, right? And we're like hoping, because imagine finding out that, it's longer than that, and we had a problem with DCD policy, right? But anyways, there's a QR code there if you want to read that study in full. So we now knew that the 5-minute observation period is sufficient. We know that circulation stops, but what happens to the brain, blood flow and activity? And why does it matter? Because, well, it matters for donors, their families. Like, we don't want to be harming the donor when we're recovering organs. We want to make sure that they're not suffering. And before, it's like folks come to us and say, well, can you reassure me that my loved one's not going to suffer? We're like, yes, but a lot of it is just based on our feelings, really. There's no good data to support this. So this is how NeuPaRT is being done. And NeuPaRT essentially will record brain activity and brain blood flow using the same paradigm, 10 minutes baseline, then for duration of the dying process after removal of life-sustaining measures, and then for 30 minutes after circulation has stopped, using EEG and transcranial Doppler. And it will inform DCD ethics, policy, and practice worldwide with respect to 2 things: death determination. So should we be declaring death at the 5-minute mark? Maybe it should be later. Maybe it should be earlier, right? There's data coming out from pig studies where the brain activity persists for a long period of time. What does it mean, right? So we need human data. And with respect to postmortem intervention, is normothermic regional perfusion is that technique shown in the very bottom. And essentially what NRP does is that puts the patient, the donor, after they've been declared dead, in the operating room they put them on the regional ECMO circuit that perfuses organs in the abdomen or in the chest and abdomen. And the reason for doing that is to reverse the ischemic injury that those organs have sustained during the dying process. One of the most devastating outcomes of DCD practice is inability to donate, right? For the recipients, because they miss out on the opportunity to receive a life-saving organ transplant, but more importantly, also for our donor families. Donor families have already lost their loved one. They've accepted this loss, right? Then they consent to organ donation, and they go through a, sometimes 48, 72, sometimes even longer period of time where they find the perfect match and they do all the workup for donation. And then the time is set for a DCD. We will start the withdrawal, and the dying process takes too long. Okay, the loved one doesn't die in time, or the organs suffer too much injury from ischemia. And when they're trying to recover in the operating room, they look at them and they're not suitable for transplantation. And so the teams walk away. And that's been described as a secondary loss, right? So it's a real thing that donor families have communicated. It's been spoken a lot about. And well, NRP stands to almost completely obliterate that, because we can take organs that have suffered ischemic injury, like liver, which is very sensitive to ischemia. In majority of cases, the dying process takes longer than 20 minutes. The liver team will walk away. They can take that organ and reverse ischemic injury to the point where the outcomes are comparable to liver's donors after neurologic determination of death, right? So it's a very powerful technique. However, what we don't know is there perfusion to the brain, right? What if there is a collateral perfusion? What does that restore brain activity during this process in the operating room, right? That can cause donor harm. So that's why our group is being involved in this, and we're going to be the first center in Canada to implement this in a context of a research study, because we have the NeuPaRT capacity, essentially. This NRP is being practiced as a standard of care in a lot of countries in Europe and in Spain and in UK and Canada and US. They started doing it, but the whole concept of the risk to the donor with reperfusion of the brain has put UK program on hold, and it caused massive controversy in the States that is risking injuring trust in organ donation, right? And we want to avoid it in Canada, and that's why we're going to do this in the context of the study. But back to NeuPaRT. So NeuPaRT is a prospective multicenter observational trial, which in English means we're observing patients from the withdrawal and recording the data prospectively. We're doing it at multiple sites: London, Calgary, Ottawa, Kingston, Montreal, with a leading center. And we're observing patients. Trial means just we're doing it in patients. So enrolling patients to undergo withdrawal of life-saving measures, we add EEG and TCD before withdrawal, and then we monitor for 10 minutes, and then withdrawal happens as per usual practice, circulatory arrest, and then we'll leave the kit in the room for 30 minutes. And that's what it looks like at the bedside. Now, how can you help? We already enrolled 25 of 90 patients thanks to your help and participation. So we're doing great, but we really need to enroll as many patients as possible here at this site, because we're experts in this stuff. Two things: you can notify study team before withdrawal of life-saving measures. And the question is, like, how soon before? Is it during the pause? That's great, but that usually you can see that this is a lot of complexity. Putting EEG on takes time. I tried to learn it. I couldn't. So we now have EEG techs doing it. I do the TCD, but it takes me a bit of time. So it takes time to set all of that up. And our EEG techs who are part of the study are not on site, so we have to call them in from home. So we need a bit of time. So the best time is if you know you're going to have a withdrawal of life-saving measures discussion, or if you've just had it and the family accepted it, that's the best time to notify the team and introduce them. And the team will have a discussion about consent, show them the study materials, explain that they will have pictures, and they will explain it. And if the family then consents, we will work with the clinical team to set up the withdrawal process. The other one is to facilitate research discussion and family and substance decision makers. Just like with organ donation, we want to slow things down. End-of-life care is a process. And so helping introducing the research team, like Sophie and Courtney, to the family, so they can have a discussion with them, and then not withdrawing life-sustaining measures immediately, allowing poor Murat to come in and and figure out how the DCD works for the hundreds of millions time, and actually have EG techs are excellent. They do their job excellently. Me, I do my best, but I can still get it on. But it takes time. Like, it takes about an hour to set all of this up. And I wouldn't give expectations to the families, because sometimes it takes an hour, sometimes somebody's delayed because there's parking, no parking spots, and so on. But we do our best to do it as soon as possible. Once everything's in place and recording, we walk out of the room, and the rest of withdrawal happens as per usual care. For the RTs in the room, the big thing here is once you have that head frame on with the TCD, sometimes you have those pulse ox, so there's the thing that holds down the tracheal tube. I try to loosen it up and be careful, like at extubating, because if you manipulate the head too much, the probes will fall off essentially, right? So just coordinating that. When NeuPaRT study was happening before NeuPaRT, we actually did a pilot study here in London. This is data from there. On the y-axis, you have EEG amplitude. On the x-axis, you have time. 0 means circulatory arrest. This vertical line is circulatory arrest. And the solid line is the average, and the gray is sort of the variance around that across patients. And what we found is that activity stops about 78 seconds before circulatory arrest, okay? This is first in the world data from humans demonstrating this, which is definitely reassuring to the community, to the practice, to the policy and ethics of DCD, that the DCD patients are not suffering as part of organ recovery. But what was interesting is when we first pitched the NeuPaRT study, people thought we were crazy. Well, actually, first when we pitched NeuPaRT study, people said nobody will ever consent to this, and we said, yeah, 100% no one, but we should try, right? So we approached families, and the consent rate in NeuPaRT was 95%, which is higher than most of my studies, right? And it's interesting because we think like families are exhausted, they're done, they just want everything to end. But the families actually, when we did an interview study as part of NeuPaRT, said they saw this as a way for the loved one to meaningfully contribute to society and future patients, right? And so they see it as leaving a legacy. With NeuPaRT, we had a slightly lower consent rate because it's adding, new monitors. It looks different. And some families were just like, that's too much for us. And we totally understand, that's fine. But still, they agreed, right? And so before we started either NeuPaRT or NeuPaRT, I would have said, that's insane. We will never be able to do this. And so not only this is informing, DCD practice or our understanding of neurophysiology of the dying process and how everything operates. Neuroscientists are very interested in this work, but it's also changing the paradigms of how we do research. So in terms of research methods, that end-of-life care research is possible and should be offered to families as a way of leaving a meaningful legacy as part of their end-of-life care. So I'll end there, and we'll